Hello, good afternoon, everyone. I am Nancy Deutsch, and I am a professor here at the University of Virginia's School of Education and Human Development. And I am the co-director of the Thriving Youth in a Digital Environment, or TIDE initiative, with my colleague Bethany Teachman, and we're really excited to be co-sponsoring the Society for Digital Mental Health conference this year. Welcome to the Flash Talks on Track 4, Enhancing Mental Health Among Marginalized or Underserved Groups. We have 4 talks for you today. Each talk will be 5 minutes, and we will follow that with 5 minutes of questions on that talk. And then there should still be some time at the end for questions, overarching questions across the talk. When it comes time for questions, you can feel free to unmute yourself and ask a question, raise your hand, and then you can also put questions in the chat. You can feel free to do that as you go along, or just at the end during the question session. But if you have a question that comes up for you during the talk that you want to make sure you remember, please feel free to use the chat for that. And with that, we will go ahead and get going. And we are starting with Alyssa Gorkin and adapting a single session intervention for transgender and non-binary youth to prevent suicidal thoughts and behaviors.
Yes, thank you for that introduction. My name is Alyssa Gorkin. I'm a research study coordinator working with doctors Pablo Zapata and Jessica Schleider at Northwestern. I'm really excited to talk a little bit about our current project, adapting a single session intervention for transgender and non-binary youth to prevent suicidal thoughts and behaviors. And to get us started, I'd like to go over a little bit about what we know. I'm sure many of you are familiar with the concept of minority stress, but as a quick refresher, minority stress refers to the unique stressors that marginalized individuals, including transgender and non-binary youth, face due to the interplay of different social contexts and discrimination and stigma across these contexts, increasing their risk for physical and mental health issues, including suicidal thoughts and behaviors. For example, in the literature, we know there's a link between incorrect name and pronoun usage, family rejection, and lack of access to gender-affirming care, and both increased risk and rates of suicidal behaviors for transgender and non-binary youth when compared to their cisgender peers. One way to mitigate this risk is through safety planning interventions, and these can be done either provider-delivered, both lay and professional, or in a self-guided format, both written or digitally. However, standard safety plans don't always fit. Why? These tools often lack specific stressors that trans and non-binary teens experience. For example, one participant in our study indicated that being non-binary is really broad and they struggle to find resources that are intentional with their experiences. You'll see here an example of an electronic safety planning intervention, and this is what our current project aims to adapt. We're using the acceleration creation to sustainment model in order to do this, or the ACTS model for short. And this focuses on creation and then reevaluating the product until sustainment. And it's a really iterative process. We're currently focused on the creation phase. So what we're doing here is intensive qualitative assessment, in this case, in the form of individual semi-structured interviews with an advisory board in order to really design and adapt the program to meet the needs of trans and non-binary youth through multiple rounds of human-centered design. And we're doing this with 12 trans and non-binary youth, ages 13 to 17, all with a past history of suicidal thoughts and behaviors. And working with these youth, I can speak from it, it's been really incredible. They have such important insights and passion for doing this work and getting involved with research. I've really enjoyed getting to meet them and work with them. And from our preliminary HCD work, what we're seeing is that crisis tools really do miss the mark for trans and non-binary youth. And when I speak to this, I don't just mean safety planning interventions. So participants have stressed the importance of thoughtful and relevant design aspects that are aligned with the needs of the community. Participants have indicated that calling hotlines, even those that are LGBTQ plus focused, miss the mark, with experiences of misgendering, dismissal, and invalidation really coming to the forefront. Next, embedding minority stress is important, but it needs to be done intentionally and with care. Participants highlighted the need for safety planning tools to reflect the unique triggers that they experience with affirmative coping strategies, but also to allow them to decide how much of that content they want to interact with. For example, one participant suggested that being later in their journey meant that they really didn't need that kind of information, and that seeing it in a context that was crisis surrounded might make them feel worse. However, another participant suggested that having that educational information could be grounding and empower them to share with others why it's so important that they use the correct names and pronouns, for example. Last, and certainly not least, digital tools must allow for personalized, not prescriptive engagement. Participants often indicated that they'd heard of safety plans, many of them had made it, but they weren't interested in going back to them. They miss the mark on tone, and they're often not interactive, and they don't have features that really motivate people to think, oh, I should go back and use that. For example, one participant indicated that statistics are really alienating, and this idea that everyone feels this way sometimes actually doesn't make them feel better. And in many contexts, the idea that lots of trans and non-binary youth have suicidal thoughts and behaviors makes them sad. And that isn't really as uplifting as we might think. And similarly, the idea that these websites we're sending them to are written with a calm and collecting tone reads more like invalidation and this kind of kumbaya feeling that makes people feel really out of touch. So lastly, I want to go through some of our design implications. We're thinking about these really interconnectedly and how our user journey allows youth to engage with the content that they want. That meaning that minority stress will serve as a contextual factor rather than trying to re-educate people who are living this experience. They know what it means to live in a world where you do face unique stressors that might not make you feel good. And lastly, and something I'm most excited about, is really untraditional approaches to content delivery, focusing on a tone that really does meet youth where they're at and validates their reality while remaining approachable and relatable. We're really centering this around something like dark humor, and I'd love to talk more with anyone who's familiar with that, but thank you. I'm open for questions.
Thank you so much. Any audience members or other panelists have a question, you can type it in the chat or feel free to unmute yourself now. So I'll go ahead and ask a question. Following up from the last slide you had about the dark humor also intrigues me, how you're using that. And I was just curious in terms of both that and the minority stress model, what does it look like? I wondered if you could describe what it looks like to have the minority stress model embedded as a context in the intervention. If you could maybe give a concrete example of what that might look like.
Yeah, so something we're thinking a lot about is dysphoria, for example, and the experience of what it feels like to be misgendered when, you know you shouldn't be. But also we know that that experience is associated with an increased rise in both intensity and experiences of suicidal thoughts and behaviors. And so most safety planning interventions aren't going to have gender dysphoria or being misgendered as a trigger to select from. And even in many cases when these are being developed with providers, if gender identity isn't a central part of the therapy process, it's also not a central part of safety planning. And so having minority stress embedded means having it there without having a participant having to ask for it or to say explicitly, I need to talk about dysphoria when I'm thinking about my suicidal thoughts and behaviors, but to really have it readily accessible in a way that isn't further alienating. And then with the dark humor, a lot of this is like calling it what it is. Feeling bad feels bad. Like there's no positive spin on that. Suicidal thoughts and behaviors are hard and they're scary. And yeah, they happen to a lot of people, but like when you're actively feeling that way, what we're hearing is that doesn't work. And so really getting creative with validating it. And I think the word millennial has come up in every one of my interviews, that like they don't want something that feels like it was written by a millennial, which like I personally am not, but it's been a really interesting kind of tension to strike of like how can we get the skills and the content we need without distilling it so intentionally that it's clinical and unapproachable.
Yeah, I really love your presentation. It's really great work, especially because I've done safety planning with suicidal youth that are, non like that have gender identity issues, and I think especially what you're saying about safety plans, like we're doing our best, but safety plans don't, like you said, they don't really pull people back, right? And I think the people who do use them find them helpful, but it's hard. And I also agree with what you're saying, where I think this like tone that's for some people, a professional tone might feel really soothing and reassuring. For other people, like you're saying, it's actually just like it just creates more distance. So it's a lot of what I'm seeing in my own work too. So I think it's really exciting to see kind of like what you're saying. And also, and this is like the era of customization and
Yeah.
making things custom. So this idea of like build minority stress in is really just like going along with what we can see people are capable of doing nowadays.
Any other questions on this one? We've still got about a minute and a half before we have to move on. Anyone else like to ask a question? Alyssa, would you mind sharing your email one more time? Great. All right. That's already in the chat. Thank you. Anything else? All right. In that case, we'll move on to the next talk and we can continue to have questions for Alyssa after the rest of the talks as well. So we're going to move on to talk number 2. Dr. Marvin Avalos and Innovating Mental Health Care for Latinx Communities, a pilot study on Samurai.
Yeah, thanks for that quick intro. I appreciate it. And welcome everyone to the conference. I hope you're having a great time. I would like to say here in San Francisco, because that's where I'm located, but I know you all are joining from everywhere. So yeah, this is my talk. It's called Innovating Mental Health Care for Latinx Communities. It's a pilot study in Samurai. A disclosure, this is, I work at UC Berkeley as a postdoc. Julio Fu and Luis Suarez are co-founders of Samurai, and this study was sponsored by a grant from the California Healthcare Foundation. But what I'm presenting, it's the research that I conducted, and any opinions that come out of this are my own and none of the founders or the funders. So as we know, there's, I hope we all know, there's a lot of disparities in mental health care for vulnerable populations, including Latinx. And parts of the reasons why these barriers exist is just because of access barriers like cost, availability of providers, but also just lack of culturally congruent mental health care options for Latinos, particularly Spanish-speaking Latinos. And so we believe and we know that digital health solutions can help reach these vulnerable populations and increase access to high quality care and supportive services for Spanish-speaking Latinos. And so the goal of this study was to evaluate the reach, the engagement, and the acceptability of this online language, psychosocial, and emotional wellness platform known as Samurai among Latinx adults. So really briefly about Samurai, it's an online platform. Let's see, questions in the chat. Okay, cool. There's an online platform that offers psychosocial, emotional Spanish language services where appointments ranging between $20 and about $60. And they're staffed by Latin American providers. And so Samurai recruits providers from Mexico, Argentina, who have a clinical license, who are licensed in their home country, who have been practicing for at least 5 years. And they are able to provide essentially kind of like telehealth services or remote coaching supportive services from their home country to Spanish-speaking Latinos in the US and really anywhere they might be. The workflow that Sandra has established is pretty quick. Somebody can just go into the portal online, find somebody they want to meet with, select the availability of that provider, enter some basic demographic information, payment data, and then the session is scheduled. It's important to clarify that these are not considered mental health treatment services in the United States, but rather just coaching or social support or emotional supportive services. I evaluated data from their based on 4 years from 2020 to September 2024, and I evaluated all their claims data essentially, right? So how many appointments users had, how often they were scheduling appointments, and some basic demographic data that we knew from them. And here's just a quick snapshot from what we gather. It's like about 60% of their sample or the users were female, 40% were male, and they came from wide range of states. I highlighted here the top 5 states from which they came from, which coincide, with the representation of Latinos in the U.S., right? So makes sense. Where there's more Latinos or Spanish-speaking populations, that's where we see the greatest concentration of appointments being scheduled. But another key thing to highlight this is too that these larger areas that you see on the map also coincide with areas that have the highest rates of medical shortage of professionals, indicating that even within English speaking languages, there wouldn't be enough providers to meet the needs in these larger demographic areas. So then you can start thinking about like, well, if there's already high shortages of mental health professionals in English, I can only imagine how much worse it would be for Spanish speaking. So um, and then what we've seen over that time period of 4 years, nearly a 50% quarter-over-quarter growth rate for Samurai, both in new users and existing users, which I think really speaks to the need of Spanish language, quality, accessible, affordable healthcare. In terms of engagement, what we found was that 67% of users engaged with Samurai for at least 2 sessions. And then
Right.
I don't know if that was a question from, okay, I don't think that question was for me, but I'm happy to take questions in a minute. And then also found that 43% of users were able to get an appointment within the next day, with 96% getting an appointment within the first week. And I'll talk a little bit more about why that's significant in a minute. In terms of acceptability, we found that there was a high satisfaction rating for their sessions with a 4.8 out of 5 rating, and 95% of respondents to a questionnaire said that they would schedule another session with Samurai. And then we also see the representation of, I see my timer going up. We see that users are coming from wide range of Latin American countries and representing various states. And so to summarize, what we found is people are seeking support for general mental health needs, to deal with family stressors, particularly immigration-related stressors, and for self-growth. Some of the barriers to accessing local care have to do with cost, lack of health insurance, accessibility, no providers, lack of cultural fit. And this is where Samurai has met that need, providing access to Spanish-speaking providers, access to flexible services, and how people choose to pay for it and schedule their appointments. They're cost-effective relative to US-based care, and they perceive providers as helpful and professional. Thank you so much. I was really fast. I'm happy to answer any questions.
Thank you so much. Questions from the audience? So I'll go ahead and kick us off with questions again then. So I'm curious, so you did interviews. I'm curious when those interviews were done and the context. Obviously, I think the context, you saw growth in the intake, and you mentioned immigration-related challenges, and I'm curious about the intersection of sociopolitical stressors that are happening with families and immigration right now, and sort of what that looked like for families engaging with the tool. Talking about
Yeah, absolutely. So the Samurai conducted just regular user interviews. They invited folks to participate in longer qualitative interviews via Zoom. And those were conducted at the same time the evaluation period was conducted. So for those 4 years between 2020 and 2024. And we did, I did find, some of the respondents talk about feeling afraid for their family or needing to kind of be well themselves, right? So they could provide for their families back home. At the time, what we're experiencing now with the current immigration rhetoric and actions was not as salient as when some of these periods were conducted. So there wasn't a lot of rich data in that aspect. But we did see a lot of rich data around COVID time and people talking about feeling homesick, right? And feeling disconnected from their communities here, but also from their families back home, and not having the flexibility to travel to visit family. So Yeah, great question.
So are these providers abroad?
They are. They
How
are.
did that work with the licensing and all of that process?
Yeah, so that's one of the reasons why I think Sandarai, their providers are explicit that they're not offering therapy. They're not offering therapy here. There's no billing to insurance. There's no diagnosis. And so the services are more on the coaching side and psychosocial wellness supportive side. Um, yeah, it's a
How
great
well
question.
did they know things like the immigration issues or acculturation issues? Since it's something
Um,
that you brought up. Like the how since those were providers were kind of in home in a different country, how much were they able to provide support around acculturation and immigration?
yeah, you know, I that's a great
Oh,
question.
sorry.
I don't have those data. I know, right? Um, I don't know, right? Like, I think, what we do see from the qualitative data, right, is that users are reporting feeling heard, understood, respected. They're feeling a level of connection, connectedness to their provider. I think the ability to be able to choose somebody not just based on language preferences, but also approach, right? Like, even some people talked about choosing somebody based on age or religious preferences. I think that would increase the therapeutic relationship, so that somebody would be able to empathize and provide right supports around US based sensitive topics.
Well, and you also kind of point to something really important where it's like Spanish speaking or not, that's like your choice, as opposed to like they're all Spanish speaking and you have more needs than just that one
Exactly.
language thing. So that's a great point.
Exactly. Yeah.
And I think there's a real connection there to the idea of customization, right? From Alyssa's talk, and the idea of really trying to understand the match between what individuals are seeking and need from their support, right?
Yeah, absolutely. Yeah, no, and that's a good point. I think often our systems, larger systems, are not designed to provide the level of personalization. It's sort of like you get whatever you can get, and you should be grateful for it. And what we see with some of the users that responded to the qualitative surveys, like the ability to have the choice, right, and to go and select something that they are choosing to participate in was extremely valuable. Mhm. Yeah.
Great. Well,
Thank
thank
you
you
all.
so much.
Mm.
We can take some final questions at the end. But next up, Dr. Ilan Giroy and Brianna Casido, with text message group therapy design recommendations among racial ethnic minority peripartum mothers with lower socioeconomic status, an exploratory qualitative study. You
There we
are
go.
still muted. Yeah.
Okay. It's only been a couple of years. One moment. Okay. Yeah, so my name is Alon Giroy. I'm a child, adolescent, perinatal, and adult psychiatrist and T32 postdoctoral fellow and Sorensen Foundation fellow up at Stanford. I'm joining faculty in the fall, and I'm here with my lovely research associate, Brianna Caicedo. Thanks for the whole, like naming the whole gauntlet that is the title of our presentation. So we have no disclosures, and this is our funding. So peripartum depression is the most common complication of childbirth and affects about 30, like almost 1/3 of minority mothers with low socioeconomic status. So it's a really big problem. And importantly, the effects of peripartum depression have lasting consequences, not just on mom, but also on the baby, other children, and intimate partners. And so one of the great things about intervening here is it's like a point where you can intervene on a lot of different people and a lot of different levels. And so a little bit of background is that thankfully there are great peripartum depression treatments, but many barriers actually prevent people from accessing them. Additionally, mothers often turn to social media and other online platforms for peer support. And in this service gap, there's a lot of ways that people are connecting there. Additionally, mothers with low SES often value peer support over expert opinions and is an important service gap in the care that we provide. And so in this context, we're this is what prompted the development of text message group therapy for peripartum depression. So we're defining text message group therapy as a synchronous group therapy led by a licensed psychotherapist consisting of live written text message exchanges with a couple of patients, about 3 to 6, that have regular meeting time, so defined start and end time. And we're building this using an iterative human-centered design, and this is a multi-phase study. So in order to kind of develop the evidence base, I did a cross-sectional study looking at the necessity and acceptability of text message therapy among peripartum mothers. And we found that they are open to it, are willing to try it, and that there is a need for it. And then we dove down and did qualitative research looking at the viability needs and acceptability with the subpopulation among racial ethnic minority mothers with lower income. And we also found that it was necessary and acceptable. And so in these, we dove down to look at the design recommendations. So again, kind of ask the people who might be using it, ground the intervention in this community it aims to serve, and that's what this presentation is about today. So our methods is this is a qualitative exploratory study. It was semi-structured virtual focus groups that allowed us to do in-depth interviews, and it was focused on mothers of babies. So I'd given birth in the past 24 months. And because we used theme saturation to determine sample size, we had 12 mothers, and we used grounded theory with Krippendorf's alpha set to greater than 0.8 for inter-rater reliability.
And then given the time that we have, I'll be providing an overview of the results. So here are the themes that emerged from our qualitative analysis. We had characteristics of helpful resources, wanting content to be relevant to my situation, avoiding group conversations because they can be toxic, wanting help, not advice, needing to connect emotionally, and suggested features. And so we'll be diving into just a few of these. So first we have needing to connect emotionally. Here participants mentioned wanting a space where they could talk to other people who understood them and what they were going through, and also just wanting kind words because kind words go a really long way, especially for this population. And then we have wanting help, not just advice. Here a participant highlighted wanting to be shown how to do things, not just told how to do things. So there was a big difference between those forms. And then we have avoiding group conversations because they can be toxic. So here one participant highlighted kind of refraining from engaging in a group conversation because they didn't want to partake in the kindness of it. It's just something they didn't want to be a part of. And then also we saw participants mentioning that they would check out from group conversations when they became more toxic than helpful, as this participant highlighted, who really needs that when we have our own stress. And then we have suggested features, the role of a moderator. So here participants mentioned wanting this group to be moderated by a professional. The presence of the professional kind of showed them that this group could actually be helpful for them, and also eliminated this fear of the group being another black hole of worry for them. And then we had suggested features, timing. Here participants differed on their preferred timing of the group. Some wanted set times, others wanted it during non-working hours, some wanted to be flexible with life. And then lastly, we had group size. Here participants wanted the group to be small with less people.
These are our mentors, Eric Kuhn and Randy Semple. Roya also helped with the analysis. All right, any questions?
Thank you so much. We open it up to questions from the group. Feel free to unmute yourself or put your question in chat.
I was wondering why you chose to use grounded theory.
Yeah, so part of this is because it was an exploratory study. So no, people hadn't done it with this population before. And we actually had pretty open-ended questions. And it's been used to develop interventions for healthcare before. So.
Yeah, thanks for sharing that work. It's we do text-based interventions in my lab, and so I'm always curious to learn more about it. One of the feedbacks that you all got was people wanted to be shown, not told what to do, right? But how do you translate that into a text messaging intervention?
Yeah, so Brianna, do you want to answer, or do you want me to answer it? Me? Okay. So basically the way that, like, there's more quotes, but what they were talking about is that they want practical guidance rather than just opinions or like attitude. So for example, around breastfeeding, Like, we need more, like, let's talk about it, more education around these things, provide us examples, or for potty training, which I think is specific to this population. A lot of times these groups more focus on like, thoughts and feel like emotions, but less kind of things relevant to taking care of babies. But I hear what you're saying. The other thing is we're actually we've already built the platform and are doing user-centered design and beta testing it, but we're adding videos as a feature based on the kind of the pilot data.
And so the texting will be through an app or through like a web browser of sorts, not like SMS.
So right now that's the form, but we're developing the intervention because of HIPAA is the short answer. So yeah, Stanford Tech had like kittens when they thought we were just going to do it via text message. So we had to build a HIPAA compliant platform. Any other questions?
Well, I think I figured out, I think this was answered in the suggestions for recommended features, but I was interested in the idea that it came up that they actually didn't like groups, right? That it was avoiding groups. And it was like, oh wait, but this is a group, a text group. So what makes this different?
Yeah.
My guess is that's linked to the size and the moderator, but curious if you have other thoughts about like what differentiated this, because it was still a group. So
Yeah. So, they said like the best experiments are already done by nature. And so moms already are doing WhatsApp group chats. I mean, a lot of us are in group chats and they can get like black holes of worry or get really toxic. And then on the other hand, we have therapists doing one-on-one sessions. And so this combines both of them where you have the lived experience with practical advice of people who are going through it with someone who has skills to keep the conversation healthy, prevent one person from dominating everything, that there's like rules basically about how we treat each other. And so combining those two things, the role of the moderator then is to kind of help provide that, especially they ask that it isn't just like another person who's like the indicated moderator, but someone who actually has skills in managing groups and preventing it from becoming toxic. So, which I think we have all experienced with that on the internet.
any final question? All right. So we will move on to talk number 4, Dr. Stephanie Zawada. Digital phenotyping can predict mood after cerebrovascular symptoms and may reduce mental health access gaps for stroke survivors in rural regions.
Thank you for letting us include our whole title there. I'm going to go ahead and try to get my PowerPoint shared. Can you see my screen? And I'll put it in. Okay, perfect. Thanks, everyone. Continue to share. Hi, my name is Stephanie Zawada. I'm an instructor of neurology at Mayo Clinic, and today I'm going to talk to you about some of the work my colleagues and I have been working on. So we're going to outline some challenges to just what post-stroke depression screening is, and then we're going to review the digital phenotyping case study my group and I have worked on, and then highlight the clinical implications. Excuse me. So about 1/3 of stroke survivors end up to develop what's known as post-stroke depression, or PSD. And it's a risk factor for mortality and morbidity, short and long-term disability, as well as future cerebrovascular diseases. And for the 1/3 that develop that PSD after their initial stroke, the majority do end up getting some type of recurrent depression, even if it subsides in the first couple months. They'll come back or experience it in the years after that stroke. Sorry about my slide there. And so PSD screening, what's the state of the art right now? It's just not routine around the country in the United States. So the heterogeneity of symptoms also complicates the differential diagnosis process. Sometimes it presents as cognitive impairment or overlap there, as well as overlap with post-stroke fatigue, and then implementation of guideline recommendations from organizations like the American Heart Association and the American Stroke Association. It's limited. Sometimes it's because of resource issues, so not all centers are capable of screening for depression specific to a stroke. And then there are staffing shortages, as everyone's well versed on this call. And there's also an unclear cost benefit analysis for implementing the screening specific to depression, even though we know it exists. Can patients engage after they get that diagnosis and get the treatment that they need rather than just get a diagnosis? So what we did was we tried a digital phenotyping case study. We used the BiWe app, and we used some data from the sensors in participant smartphones, and we tried to evaluate the performance of different behavior measures captured from those sensors, as well as standardized self-report surveys to predict depression severity in our rural and remote patients who had cerebrovascular syndrome, so stroke-like symptoms, a stroke event, and transient symptoms as well. So our aim was to investigate whether passive and/or active smartphone data could predict clinical grade depression severity scores. So the Montgomery-Åsberg Depression Rating Scale, or MADRS, was used in this case, and it's the gold standard for depression screening after a stroke. Our population was long distance and rural patients at Mayo Clinic, Arizona, with ischemic stroke, or TIA, transient ischemic attack symptoms. And we conducted an observational study using participant smartphones, and we captured active or survey-based data and then passive or sensor-based data using the app I mentioned. Just recapping the measures again. So when I talk about surveys, I'm talking about the patient health questionnaire, the PHQ-8, then the gold standard mood assessment is the MADRS, and then passive smartphone predictors, that's data that comes and is processed from accelerometer, GPS, and screen use sensors. This is just an outline of what type of a study design we use. So every 30 days, we would do that MADRS clinician grade assessment. And then on a weekly basis, patients would submit their PHQ-8 surveys themselves from within the app. And on a daily basis, you would get that streamed accelerometer, GPS, and other device data. What do I mean by the passive predictors? So to give everyone, if you haven't worked with these types of tools before, but just to give you an idea of a background, we're talking about when you get an accelerometer sensor, things like cadence and number of steps, or GPS can capture number of significant locations you're visiting, or the distance traveled from home. Those types of measures is what we're talking about. And then for screen use sensors, we just use survey completion time and seconds for the PHQ-8. We took a thoughtful approach to processing the data. So we used a time averaged approach, which was every time you had an MADRS assessment, we took the 7 days prior and averaged the different measures that I talked about. And then we used principal component analysis. Since the sensors were all within one device and they correlate, we wanted to make sure that we just used the one principal component in our models to account for that overlap. We used leave one subject out cross-validation and then took an average root mean squared error for each participant in our data set. And we applied standardized approaches for using the forest package associated with that app to deal with imputation and interpolation methods that weren't naive and could help us make a contextual interpretation of GPS and accelerometer data. So what did we do? Well, we were able to enroll 54 participants. 44 got started in the program, and 35 actually completed the project. This was just over about a 5-6 month period. And our patient population was majority male, on the cusp of older adulthood, majority white, and also majority iPhone users. And then around 1/4 of our patient population had multiple strokes. So either multiple ischemic strokes, multiple TIAs, or a mix of both. So when we were looking at the models that I talked about, we included those patient-reported surveys and then looked at including different types of sensors from the smartphone. And we found that basically the more sensor data that you could include from the smartphone, it looks like it might be canceling out noise, and it can help improve the prediction of those MADRS scores. So the strengths of our study, it's the first approach to trying to get a phenotype for cerebrovascular diseases. It's been done in psychiatry, but not after a stroke admission. And we were able to do a long-term 8 to 12 week study collection period, compared multiple sensors. And then limitations is, again, the smartphone data has a sampling on-off frequency, so it's not continuous, it's near continuous. It's a new study, so there aren't comparative validation data sets. And last year's iOS software update did cause some battery drain there towards the end. We didn't compare weekday versus weekend averages. And then patients do put their phones down, for instance, at night. So that's a separate issue to get into. So conclusions, combined sensor models were more accurate than just the single sensor models. Active and passive data appears that it might be useful in triaging patients that are rural and in these remote regions in our patient populations who might not normally get depression screening. And so our takeaway is that real-world monitoring might increase access to behavioral care after a stroke in these patients who traditionally wouldn't receive follow-up screening. And I thank you all for listening.
Thank you. Questions? Unmute yourself or put it in the chat.
I can jump in with a quick question. Thanks for your presentation. So you were collecting the sensor data weekly, right? It sounds like, and the gold standard assessment just at the 30-day.
Around that period,
Did you
yes.
talk about the recency of the sensor data for predicting the depression scores? Was it like the week of? Was it just the cumulative? What was the timing effect of that?
We did the week of, and that was because that was standard in the literature. So with a handful of those apps that will collect the smartphone data, we did find that they would use the 7 days prior. So if you got the assessment, say, on a Saturday, we took the 7 days before that Saturday and averaged the measures before that. There is a growing body of literature that says, hey, why don't we start looking at maybe just the 3 days or 4 days and trying to find a sweet spot with different patient populations? So thanks for your question. And yeah.
And then a follow-up to that, because I don't know much about depression after TIA other than my dad went through something similar. Is there like a time that you would then expect to see some of the depression show up following this stroke period? And were you able to predict any of that through your study?
We were hopeful. We actually weren't able to predict it. Unfortunately, it was too small of a pilot study. So that's the next step. We'd like to see that in the data set. But yes, usually within like those first 7 days is when you'll track patients. And we actually did a prototype study where the patients we had, it was too burdensome to do it that first week out of the hospital. We met with family and we did publish a little small perspective study on that. And it was too burdensome for them that first week. And then people like a week or so after would say, I want to do this study. Can you help me set it up? So unfortunately, that's kind of a great week where you'd be able maybe ideally to get that data. But once we actually tried the hypothesis in the real world, it wasn't feasible with the smartphone app. Now that could be a separate place for maybe wearables to come into play and process the data that way. So I love your question. And that's usually that first week. And then within the 3 months is when you want to measure. Thanks.
Yes, so I think that's interesting. I was also thinking about not just the time right after the event, so time since event, but I was also wondering about the flow before and after the measurement, and if you could see. So I guess at this point, because this was sort of just testing whether you could predict, there wasn't sort of an intervention offered. But I don't know. I wonder, did you see, because I'm curious about then whether if there was, for example, lack of mobility, lack of going out because of physical symptoms that then resolved and they increase their mobility, does that then get like what you might call natural fluctuations? I don't know.
Yeah, we did actually find that, and this paper is in proof right now, but we did find that patients who were, so our cohort had some people who, the majority had some type of a disability. So they had either lost the ability to walk for a short period of time. They were working in physical therapy on that. It was broad and we let anyone who wanted to join. So it was interesting that they were affected, at least unilaterally from their symptoms. But yeah, we did find that oddly, and it was kind of the reverse of what we expected. The patients who were happiest in their recovery period were those who were spending more time at home. We thought it would be the opposite, that, okay, well, those who are most active and engaged afterwards are probably going to report the best mood scores. And actually, it seemed that we found different correlations, that it appears like the patients who get that rest time where maybe they either are not working, or they don't have as many burdens in their daily life and they're resting at home, they had happier reported scores.
I don't have a question. I just think it's really cool that you're doing this research, because this is not often thought of as a hard to reach population, but it really is. And often by the time they come to a psychiatrist, it's like, whoa, it's been a while. And this kind of gets people in right as a part of the whole package, where they're already doing like of course it makes sense that you're doing physical therapy, but also like, brain recovery and dealing with all of that. So I think it's really great to kind of open a window to that time period.
Thank you. I think ideally too, and the other interventions that we've seen before, even the one we've just our observational study, ideally these projects could help like augment the processes already in clinic where there are workflow shortages. What could we do to help triage and present scores, or not overwhelm clinicians, but help them take a deeper dive and target this care so that the outcomes are improved and you don't just get more readmissions on the behavioral side?
Wonderful. So we have about 4 minutes left in the session. So I would welcome any questions, comments, thoughts from across the talks you've seen today from anyone in the audience. You can unmute yourself or put the comment in the chat.